All right. It is right 1 minute past the hour, so let's get started. Thank you guys so much for joining. My name's Ellen. I'm with Sona, and we have a bunch of Sona users on tonight, which is awesome. But for those of you who don't know who we are a free HIPAA compliant platform that allows offices to send selected ultrasounds and clips right from the machine to patients' phones. So it's as easy as you scan, you press a print button, and patients can get the whatever images and clips of your choosing right on their phone. So if you already are using a digital solution that is maybe costing money or is clunky, or you don't have a digital solution, I will put my email in the chat. Feel free to reach out. And then the next thing is we're going to be doing more of these free CME opportunities throughout the year. We're hoping the next one is going to be like in about a month and a half. So we'll keep you updated on those. I'm going to put just our sign up form so you'll stay in the know if you fill that out. We'll make sure we let you know when there's future free CME opportunities. Um, all right, so tonight we have, I mean, so far an amazing turnout. We had almost 300 people register for this, um, uh, representing 39 states in the US and 15 countries, which is so impressive. So it just shows there's an interest for CMEs, especially free, I'm sure, and continue learning. So we're really excited about it. In order to qualify, Heather, you raised your hand. Do you want to go off mute and speak? Or can you post in the chat if you have a question? I just realized I didn't send my email into the right chat.
I got it. I got
Um,
it in the chat.
okay. So we have a great representation of sonographers and tonight. In order to qualify for the CME, we either need your SDMS number, and if you don't have an SDMS number, we just need your birthday. So we got that from a lot of people. There's a few that are missing, so we're gonna reach out just on a individual basis if we're missing anything, so we can make sure that you get the CME for tonight. And then the last thing is in the queue, if you have any questions throughout the presentation, we are just if you can put them in the Q&A box. If you don't see a Q&A box at the bottom, if you click more, go to the Q&A box and you'll be able to see you ask questions throughout. And then at the end, we'll have a Q&A session. We'll get to those questions. If you do have access to the webinar chat, feel free to drop where you're from because there's so many different, places being represented here tonight. So I think it would be cool to see where everyone's coming from. All right, with that, I'm going to make an introduction to Lynn and then we can get started. So we have Lynn Flam here tonight who's going to do the CME. She's a registered diagnostic medical sonographer with over 3 years, 3 decades of clinical expertise. Most of that time has been exclusively in OBGYN ultrasound. She also has a Bachelor of Science degree in healthcare management. And since earning her ARDMS credentials in 1992, Lynn has dedicated her career to excellence in ultrasound practice, physician collaboration, and advancing sonographer education. She currently serves as a chief sonographer in a rural Southern Illinois women's health clinic. She has held multiple leadership roles across corporate and private OBGYN practices, and she is an experienced clinical instructor, having supervised and mentored ultrasound students since 1998. So, as a founder and CEO of Sono Techniques Academy, Lynn developed a comprehensive OBGYN ultrasound training platform designed to elevate sonographer proficiency and support providers in clinical practice. The Academy offers structured learning modules, voice-guided instruction, and registry review content, and AIUM driven education through a mobile and web-based app. All right, with that, I am going to kick it off to Lynn. Thank you.
Thank you.
All right, Lynn, you have the floor. Feel free to take it away.
Hang on. to share. Just a minute. Can you see my screen? Can you hear me?
I can't see your screen, Lynn.
Okay. I'm sorry. We did this earlier and I'm sorry. Just a minute. Oh my goodness, I apologize.
Can I help, Lynn?
Risk two. Share. I need to share my desktop too. Just a minute. But my presentation is on. Yes, you can help me. Can you see it now? Can you hear me? Can you see it now? Oh no.
No, I can't see it now. Are you clicking on share and then desktop too?
Yes. Oh my, I'm sorry. Share desktop two. Okay. How about now?
Yep.
Okay.
Right.
Okay. I apologize. And you can only see the presentation, right? Okay. Good evening, everyone. Before we begin, if you cannot see my slide or hear me clearly, please drop a note in the chat. During this lecture, I'll be using some pre-recorded audio for some of the images and videos, and I would like to acknowledge SONA as a supporter of OBGYN ultrasound education for this CME activity. The educational content presented today remains independent and evidence-based. The title of this lecture is Ectopic Pregnancies and First Trimester Evaluation. My name is Lynn Flam, the founder and CEO of Sonotechniques Academy and the host of The Seasoned Sonographer. You are the target audience: diagnostic medical sonographers, students, physicians, advanced practice providers, including PAs and certified nurse midwives. As the participants, you'll benefit from reviewing first trimester ultrasound findings, clinical correlations, and diagnostic strategies for early detection of ectopic pregnancies. The learning objectives are that you will be able to recognize the clinical presentation and ultrasound findings suggestive of an ectopic pregnancy. You'll be able to differentiate between a pseudo-sac and a true gestational sac. You will correlate quantitative HCG trends, expected ultrasound findings, and identify the sonographic appearances of an adnexal mass versus an ectopic pregnancy with a live embryo. You'll interpret color Doppler patterns, including the classic ring of fire, and apply best practices for early detection and timely referral to reduce morbidity and improve patient outcomes. This talk reviews ultrasound features and clinical considerations of ectopic pregnancies in the first trimester. Let's start with normal intrauterine pregnancies, the first trimester ultrasound. Understanding the characteristic ultrasound findings of a normal intrauterine pregnancy is crucial for accurate diagnosis and for differentiating between an ectopic pregnancy and an intrauterine. The AIUM guidelines require images in the first trimester, which include the uterus, the location of the gestational sac, the adnexa, even if you can't see the ovaries, the cul-de-sac, presence and number of fetuses or gestational sacs, the crown rump length, M mode, and if applicable, the chorionicity and amnioticity. Intrauterine gestational sacs are centrally located within the endometrial cavity. They're round and have well-defined borders. They grow at about a millimeter a day, and they're anechoic with a fluid-filled center and that thick echogenic decidual ring surrounding it. Here's an intrauterine gestational sac. You can see the uterus is in a longitudinal view. Here's the endometrial cavity. Here's the gestational sac, and you can see that thick echogenic decidual ring around it and maybe a little yolk sac there. Make sure you increase your depth in order to see the whole uterus up to the fundus, and always adjust your gain and focus. Image optimization ensures that you don't miss the intrauterine pregnancy inside the endometrial cavity. Here's a closer image of the gestational sac. You can see the decidual cast around the sac. The pink arrows indicate that thick echogenic ring. And you can see a yolk sac, a tiny yolk sac here inside of that gestational sac. The yolk sac is the first thing to form inside that gestational sac. Usually by about 5 to 6 weeks, we can see that yolk sac on transvaginal ultrasound. It should measure less than 6 millimeters. If it's greater than 6 millimeters, it could indicate a failing pregnancy or an abnormal pregnancy. It is small, it's round, it's got an echogenic ring with an anechoic center. When you see a yolk sac, it confirms an intrauterine pregnancy and helps distinguish it from a pseudosac. Pseudosacs do not have a yolk sac. On this image, a well-defined gestational sac is seen within the uterus with a visible yolk sac. The sac appears round with a smooth decidual echogenic rim, demonstrating a normal intrauterine pregnancy. No definite fetal pole is seen at this time, which can be normal in early pregnancy. Follow-up imaging is recommended to confirm embryonic development and cardiac activity. And here is a yolk sac measurement. You would measure inner to inner when you measure the yolk sac. Do not include the echogenic ring. And again, it should measure less than 6 millimeters. The fetal pole usually appears within the gestational sac at about 6 to 7 weeks. You can measure the crown rump length for dating. And cardiac activity should be detectable as early as 6 weeks. A less than 7 millimeter crown rump length, the cardiac activity may or may not be seen, and that can be normal. The fetal heart rate must be seen at 7 millimeters or greater. And once that crown rump length is measurable, it becomes the most accurate indicator of gestational age, till about 13 weeks. Here's an image of a fetal pole at about 6 weeks gestation. The crown rump length is seen here measured. And this is the ACOG guidelines for redating based on ultrasound. According to this chart, if there is more than a 5-day discrepancy at less than 9 weeks, you would not use the LMP to date the pregnancy. You would use the ultrasound dating. If the patient's between 9 and 14 weeks and there's more than a 7-day difference, you would use the ultrasound dating and not that LMP. You would change the dates. According to ACOG, the crown rump length is the most accurate method for dating and establishing that gestational age. Here's a fetal pole with a heartbeat, proving viability in the early first trimester. Based on the ALARA principle, always use the M mode to document the fetal heartbeat in the first trimester and not the pulsed wave Doppler. When confirming an intrauterine pregnancy, you must show at least one of these. You should see a gestational sac located centrally within the uterus with a decidual ring. If you see the gestational sac and it does not have a yolk sac or an embryo, it should be followed until one of those definitive structures appears. The yolk sac, visualized within the gestational sac, confirms an intrauterine pregnancy. An embryo with or without cardiac activity seen within the uterine cavity also confirms the intrauterine pregnancy. The definition of an ectopic pregnancy is implantation of a fertilized ovum outside the normal uterine cavity. Most commonly in the fallopian tube, about 95% of the time. It occurs 1 to 2% of all pregnancies and is the leading cause of first trimester maternal mortality in developed countries. Risk factors of ectopic pregnancies include prior ectopic pregnancy, pelvic inflammatory disease, prior tubal surgeries, smoking. It damages the cilia and reduces the motility inside that tube. Assisted reproduction, IUI, and IVF increases the risk for an ectopic pregnancy. Here are some of the locations of ectopic pregnancies. Most of the time, the ectopic pregnancy will lie within the tube 95% of the time. And in that tube, 70% of the time, you will see the ectopic in the ampullary portion of the tube. The sites that are very rare for having an ectopic pregnancy are cervical, C-section scars, and abdominal ectopic pregnancies. With an ectopic pregnancy, you'll see a suboptimal rise in the beta HCG or a plateauing or declining level without the passage of tissue. There will be an absence of an intrauterine pregnancy when that beta HCG is at the discriminatory zone, and the discriminatory zone for seeing an intrauterine pregnancy is 1,500 to 2,000 MIUs per ml. Transvaginal ultrasound has a specificity of 99% and a sensitivity of 90 to 95% for detecting ectopic pregnancies when combined with beta HCG correlation. Ultrasound, especially transvaginal ultrasound, is highly sensitive and specific for ectopic pregnancy, but negative scans may require follow-up with repeat vaginal ultrasounds and quantitative HCGs. Patient signs and symptoms of ectopic pregnancies includes abdominal or pelvic pain, vaginal bleeding, shoulder pain, positive pregnancy test, and no intrauterine pregnancy on ultrasound, dizziness or syncope in ruptured cases. The differential diagnosis for ruling out other causes of first trimester bleeding are as follows. Spontaneous abortion. It can look like an ectopic pregnancy if the patient's cramping and bleeding, but you will see an intrauterine pregnancy with declining beta HCGs, maybe products of conception in the uterus or cervical os, and absence of an adnexal mass. A heterotopic pregnancy is rare, but it is a simultaneous intrauterine and ectopic pregnancy. Again, it occurs at about less than 1% or 1% of the time with IVF. Both gestations can be visible on the ultrasound with the heterotopic pregnancy. Pelvic inflammatory disease, bilateral adnexal tenderness, cervical motion tenderness, fever, elevated white blood cell count, and a negative pregnancy test. Corpus luteum cysts are ovarian cysts with thick walls and internal echoes, and they may have the ring of fire, but they're less intense than the ectopic pregnancy, and you can see the claw sign of crescent ovarian tissue surrounding it or surrounding one side of it. There should be a normal intrauterine pregnancy if the patient is pregnant. Torsion, enlarged edematous ovaries with decreased or absent blood flow, or intermittent absent blood flow on Doppler, acute severe pain, possible nausea and vomiting, pregnancy of unknown location, a positive HCG without a visible intrauterine or extrauterine pregnancy on ultrasound requires serial beta HCGs and repeat ultrasounds. The overview of first trimester complications emphasizes the importance of early diagnosis in ectopic pregnancies, the role of ultrasound and serial quantitative beta HCGs, differentiating intrauterine versus extrauterine findings. Serial quantitative beta HCGs measurements are essential for diagnosis of ectopic pregnancy. That level should double every 48 to 72 hours in a normal pregnancy, the first 6 to 8 weeks of gestation. The rate of increase slows as the pregnancy progresses, reaching a peak at about 8 to 10 weeks. Then it gradually declines or plateaus for the remainder of the pregnancy. A normal rise in beta HCG supports the presence of a viable intrauterine pregnancy, whereas slower or plateauing levels may suggest an ectopic or a non-viable pregnancy. Correlate those HCG levels with expected ultrasound findings and patient symptoms. Again, that discriminatory zone is 1,500 to 2,000 MIUs per ml. If the HCG is greater than 2,000 and you're not seeing an intrauterine pregnancy, there's a very high suspicion for ectopic pregnancies. Serial trends suggest a viable intrauterine pregnancy versus an ectopic or a failed pregnancy. The ultrasound appearance of an ectopic pregnancy might have a pseudo-sac, which contains no decidual ring and an irregular shape, an adnexal mass separate from the ovary, a tubal ring or a complex adnexal mass, a possible sac with a yolk sac or embryo in the adnexa. Free fluid in the posterior cul-de-sac or Morrison's pouch can suggest rupture. A pseudosac contains fluid within the endometrium and lacks that double decidual ring. A true sac will have that decidual ring, be high up in that endometrial cavity, and contains a yolk sac. Perform a careful sweep of that endometrial cavity to avoid misdiagnosis. Make sure you're seeing all the way up to that fundus. Sweep side to side longitudinally and go transverse and look up to that fundus. Is it a true gestational sac or a pseudosac? A true gestational sac is seen located within the endometrial cavity, contains a decidual sac sign around it, the thick echogenic rim. A pseudosac, on the other hand, lies in the uterine cavity and has a single thin rim and lacks a yolk sac or embryo. Anytime you see a yolk sac inside that gestational sac, you have ruled out an ectopic pregnancy. Here is another longitudinal image of a pseudosac. You can see the uterus all the way up to the fundus, and here's the fundus, and you can see that pseudosac inside of the endometrium, and it's kind of a teardrop shape, and it contains some echoes, which is blood. Here's another pseudosac, the longitudinal image of the uterus up to the fundus. Here's the endometrial cavity here, this echogenic line, and it opens up, and you can see this pseudosac here coming to a point. It's irregular in shape and does not have that thick echogenic decidual ring. And here's the transverse view of the pseudosac. You can see the uterus in transverse section there with the blood-filled pseudosac. And here again, for reference, is the normal intrauterine sac with that decidual ring around it. It's smooth, and this one contains a yolk sac. There's a definite ectopic pregnancy when you have an adnexal mass separate from the ovary. In order to determine that, you can use pressure from the vaginal probe and or bimanual pressure using your hand on top of the patient's abdomen, pushing gently while you're looking with the transvaginal probe. And you are looking for a nonspecific mass 54% of the time and a tubal ring mass 40% of the time. Only 8.5% of the time will you see a yolk sac, and even less than that, 7% of the time you'll see an embryo with a heartbeat. So 94% of the time you're looking for a mass. There's bowel in the adnexa, and pressure from that probe can separate that bowel and reveal an adnexal mass, and then you can determine if that is separate from the ovary. A nonspecific mass in the adnexa is also called the blob sign. It is a nonspecific, inhomogeneous mass separate from the ovary and does not contain a tubal ring or a gestational sac. It looks like a blob of tissue in the adnexa. This image demonstrates an echogenic elongated adnexal mass consistent with a blood-filled fallopian tube. A hemorrhagic cyst is also seen on the ovary. When gentle pressure is applied with the transvaginal probe, the tubular mass moves separately from the ovary, confirming that this is not ovarian in origin. These findings are highly suggestive of an ectopic pregnancy involving the fallopian tube. Here is an image of a right ectopic mass with a tubal ring. Let me play this audio for you. In this image, you can see the tubal ring sign, a classic ultrasound feature of an ectopic pregnancy. It appears as a round hyperechoic ring with a central anechoic area representing a gestational sac within the fallopian tube. Color Doppler often shows a ring of fire pattern from trophoblastic flow, confirming its vascular nature. This finding is located separate from the ovary, helping differentiate it from a corpus luteum. The tubal ring sign or the bagel sign is that thick echogenic tubal ring with a hypo or anechoic center, and it moves separately from the ovary. And don't forget, add color Doppler. You can see the ring of fire here around that tubal ring sign, the anechoic center, and it is thick and echogenic. Here is a blob mass, the blob sign. You can see the ovary here. You can see the echogenic, the mass, the blob, the mixed echogenic mass, and a little bit of that ring of fire vascular flow here. You can see some free fluid that contains some blood, some echoes inside of it. And this is separate from the ovary when we push. An ectopic pregnancy with a live embryo is a definite diagnosis when cardiac activity is visualized outside of the uterus. There's often an adjacent hematoma or free fluid, and it requires emergent OBGYN consultation and surgery. An ectopic with a yolk sac and a fetal pole is seen here in this image. You can see the ectopic tubal ring, and it has the anechoic center, and it has a yolk sac and a fetal pole. And here is the ovary out to the side. And if you would push, this separates from that ovary. And here again is an ectopic with a sac and an embryo. an ectopic with a fetal pole. In that right adnexa, you can see some free fluid, which is suggestive of rupture. The color Doppler ring of fire is paratrophoblastic flow surrounding the ectopic sac. It has a high velocity and a low resistance waveform. It is not specific, as it is also seen in a corpus luteum. Correlate this finding with beta HCGs and the clinical context. Use a low PRF, pulse repetition frequency, by adjusting your scale and optimizing your gain for sensitivity. Here's an ectopic with a ring of fire. Let me play the audio. This image shows an ectopic pregnancy with a sac-like anechoic structure in the adnexus surrounded by peripheral vascular flow, the classic ring of fire appearance. No intrauterine gestational sac is seen, and these findings are consistent with a tubal ectopic pregnancy. Here is that blob sign again, and you can see that peripheral vascular flow here in that ectopic pregnancy. Again, it's a mass. It's not a fetal pole with a heartbeat, and it doesn't have a yolk sac. So you're looking for a mass most of the time. The corpus luteum versus an ectopic, when you're talking about the ring of fire, both the corpus luteum and an ectopic pregnancy can show the ring of fire. This sign is not specific for ectopic pregnancy. A corpus luteum is a normal ovarian finding that occurs after ovulation. It shows peripheral vascularity with thick walls. It arises from the ovarian tissue, and that tissue can be seen cradling the corpus luteum, also known as the claw sign. An ectopic pregnancy can show a tubal ring, or it can show the mass. It's separate from the ovary and often has that vascular ring of fire around it. The ectopic pregnancy might appear adjacent to that ovary, but it is separate from the ovary. Therefore, location and relationship to the ovary are key distinguishing features. Use a little gentle pressure from the probe or from your hand on top of the patient's abdomen. Here's a corpus luteum with the classic ring of fire. Here is a corpus luteum and a tubal ectopic. You can see the corpus luteum is less echogenic than the ovarian parenchyma here. Here is the claw sign where the ovarian tissue wraps around that corpus luteum. And here is the tubal ring ectopic pregnancy with a thick echogenic ring and an anechoic center. The tubal ring is more echogenic than the corpus luteum and the ovarian parenchyma. Does it move away from the ovary? The big takeaway is, does it move away from the ovary? That will help you distinguish whether it's a corpus luteum or an ectopic mass. Here's an image of an intrauterine sac and a left corpus luteum cyst. This is the corpus luteum. This is the intrauterine sac seen inside the uterus. And there's the classic ring of fire when we add the color Doppler. Heterotopic pregnancies. Those are a coexistence of an intrauterine and an ectopic pregnancy. According to ACOG, with natural conception, the risk is very low, less than 1%, way less than 1%. With assisted reproductive technology, IUI, IVF, the risk is significantly higher and at about 1%. Ultrasound findings will show an intrauterine pregnancy with a yolk sac or embryo, and then an adnexal mass will also be seen with the tubal ring sign or a live embryo. And there is free fluid if a rupture is present. Here's an image of a heterotopic pregnancy. You can see an intrauterine pregnancy with a yolk sac, and then that ectopic pregnancy looks like it has a fetal pole in it. Another heterotopic pregnancy, an intrauterine pregnancy, is seen here on the left, and this is the ectopic mass on the right side of that uterus, or on the left side of the uterus. You can see maybe a gestational sac there and maybe a fetal pole. Never exclude an ectopic pregnancy once you've seen an intrauterine pregnancy, especially with fertility treatment patients or patients with persistent pelvic pain. Seeing an IUP does not rule out ectopic pregnancy in an IVF patient. Key sonographic clues of rupture include a moderate to large amount of free fluid in the cul-de-sac, Morrison's pouch, the paracolic gutters. It's echogenic free fluid, which indicates that there's blood or clots in it. It's not just that clear anechoic serous fluid. It'll have echoes inside of it. An adnexal mass that is irregular or complex, no longer confined. It may appear disrupted or poorly defined. Sometimes the gestational sac can be seen outside the tube in that free-floating debris. A collapsed or distorted fallopian tube with surrounding echogenic fluid or clots is suggestive of a rupture, and an absence of an intrauterine pregnancy with a positive HCG above that discriminatory zone and free fluid is an indicator that there's possible rupture. Here is a view of the right ovary. You can see the corpus luteum cyst on the right ovary, and then next to it you can see an adnexal mass, which is a blood-filled tube, and then this is some bowel here, and all this free fluid in the cul-de-sac with the internal echoes representing blood and possible clot. This is probably ruptured. A ruptured ectopic pregnancy is a medical emergency, and recognizing the signs clinically and by ultrasound is critical. If rupture is suspected when there is fluid in the adnexa and or cul-de-sac, the patient is going to surgery. So make sure that you mention it in your report, sonographers. If you see fluid, free fluid with echoes in it, or any free fluid, make sure you put that in your reports, because that is likely an indicator of rupture. Key takeaways. Always correlate symptoms, HCG, and ultrasound. Differentiate pseudo sacs versus true intrauterine sacs carefully. Recognize an ectopic mass, a tubal ring, and a ring of fire on the Doppler. Early diagnosis reduces morbidity and mortality, saves lives, and preserves fertility. Sonographers, if you can't find an intrauterine pregnancy and the discriminatories and the HCG is in the discriminatory zone, or if it has hit a plateau, you must make a big effort to find the ectopic. Don't rush. Look again at each adnexa in both planes. You're looking for a mass. Use that probe pressure to displace bowel and to see if what you think might be a mass will separate from that ovary. You can use pressure on the patient's abdomen too. The big deal is, does it separate from the ovary? As sonographers and providers, what we do matters deeply. The difference between a confident diagnosis and a missed finding often comes down to technique, vigilance, and continued education. Our precision impacts patient outcomes every day. I want to thank you for your commitment to elevating OBGYN ultrasound. Here are some resources that you can use to further your education. The Sono Techniques Academy app is an OBGYN ultrasound teaching app. It is mobile and web. It can be used as a resource for seasoned sonographers that just need a reference. Maybe you work in a hospital and you don't see much OBGYN, and so you might not have the confidence that it takes to make an accurate diagnosis. This app will help you through that. Also, the Seasoned Sonographer podcast. It's on Apple Podcasts, Spotify, and YouTube. It's a great way to hear about ultrasound imaging and how what we do every day and what we see on those ultrasounds impacts decision making, delivery timing, and patient outcomes. Other obvious ones for sonographers are SDMS, AIUM, ARDMS, and social media. Wow, that's a great way to see some awesome cases and images. Instagram, Facebook, and even LinkedIn. Wow, and some of them give little quizzes, and you can check yourself by looking at other people's comments. It's the social media is just great. I continue to learn so much just looking at people's posts. That concludes the formal content. I'm happy to take questions. I'd like to thank Sona again for supporting OBGYN ultrasound education and helping make this program possible.
Thank you so much, Lynn. Thank you everyone for being here. We'll leave a couple minutes for Q&A. I don't see anything in the Q&A box right now.
Okay.
Um, if anyone
Okay.
has questions, you could put it there. At this point, you could also put it in the chat. So we'll leave. We'll
Yes.
we'll stay
Thank
on it.
you all for being here this evening and for the work you do for your patients. This has been a lot of fun for me to put this presentation together, and I really hope you all enjoyed it. Let's have some questions.
Awesome. And as we're waiting, if there are questions that come in as we're waiting, we will. Lynn, do you want to speak to the CME, how they get the CME, and then the eval form that you're going to email?
Yes. So make sure that when you filled out the registration form that you put your name as it appears on the SDMS site, your SDMS member number. And if you're not an SDMS member, that's okay. We just need your date of birth. SDMS will create an account for you and you will be awarded your CME, one CME credit for this lecture. Um, I will be emailing you all an evaluation form after the lecture. Give me a couple days on that. I will email you that evaluation form and then you can send that back to me.
It's optional, right, Lynn?
Yes, yes, it's
Okay.
optional. You don't
We
have to
did
do it. You'll still get your CME.
great. We did get a couple questions. So the first
Okay.
one, can you tell us what the standard measurements? Oh, where did it go? Standard measurements are for connual ectopic. Am I saying that right?
Corneal.
Corneal. Yep, there you go.
So the standard measurements for corneal ectopics, there is I'm not sure on the number, I'll be honest, but there should be a certain amount of uterine tissue there to call it a corneal ectopic.
Okay. Any tips for recognizing true um, C-section scar ectopic versus calling it too early?
Well, if there is a concern about a C-section ectopic, you'll see it into that V-shaped scar going up into the scar anteriorly. Um, I think if you see it there, it is because a normal intrauterine pregnancy should be higher up in the uterus and towards the fundus.
Okay, next question. How common are torsed FT? I've had two this past month with no significant sonographic findings. It was a surgical finding.
Torsed ovaries? that
Do you want to pull up the Q&A? Maybe you can read it. It's the third question up from the bottom. Tubes, sorry. Tubes, torus tubes.
Oh, okay. What was the question again? One more time, sorry.
How common are torsed tubes?
They're not common at all. In fact, in my 34 years, I'm not sure that I've seen one. I may have missed one, but ovarian torsion, is when you see that large ovarian cyst or ovarian mass that twists on that pedicle and can demonstrate no vascular flow in that ovary or even intermittent vascular flow in that ovary.
Um, when you measure a corneal ectopic, does the measurement include the decidual reaction?
No.
Okay. And someone said I downloaded the app. And Brittany, I'm just want to confirm it's for the Sono Techniques Academy. It won't allow me to subscribe. How do I join? We'll email you on the side for that. Okay. Thank you. All right, let's give it one more minute. Any other questions?
So I'm thinking I should have gone maybe further into depth in some of those more rare um, ectopic pregnancies, like the corneal ectopic pregnancy. Um, Live and learn.
The next one. Okay, we have one. I have a current patient that has an IUP and moderate free fluid. Edem, do you want to read this out loud? Because edemanaceous bilateral ovaries and left ovary has two homogeneous masses with ring of fire around both. Patient has pelvic pain and bleeding. My initial thought is heterotopic pregnancy, but wondering if it's possible torsion instead. What are your thoughts?
Let me go to the Q&A. Let me see that question.
Okay.
Which is the economic torus fluids. Which one is it? Da, da, da,
It's
da.
the second one from the bottom.
Intrauterine pregnancy and moderate free fluid. I mean, it could be two corpus luteum, edematous bilateral ovaries, and left ovary has two homogeneous masses with a ring of fire around both. I would think that those are likely. One might be a corpus luteum and one might be an ectopic. So it could be a heterotopic pregnancy. Again, using that probe pressure to determine if one of those can separate from the ovary would determine if one of those is an ectopic with an intrauterine pregnancy. And it may be a heterotopic pregnancy that's rupturing with that moderate free fluid. Yeah, I'm gonna say a heterotopic pregnancy.
Any other tips on corneal to ectopics?
They're rare. No.
And by the way, guys, we'll send the recording out too. So if you came late or missed anything, we'll make sure you get it. Are you able to determine the portion of the tube that the ectopic is in?
That's difficult. That's difficult because it's usually a mass and you can't tell which part of the tube it's in. You can tell if it's corneal or, right off the cornea of the uterus, but other than that, usually the mass is it's difficult to tell what part of the tube that it's actually in.
Okay. Other than probe pressure, is there any other useful technique to get overlying bowel gas to move so you can see the agnexa? I had one couple weeks ago and tried Trim's abdominal pressure and with the transvaginal probe, but could not get the bowel to move and could not prove where the ovary was.
I would say try to use your hand on the patient's abdomen while you're putting a little bit of pressure with both hand and vaginal probe to try and get that bowel gas to move. Um, that would be the suggestion that I have. And sometimes when I can't get things to happen, I'll go to the other side and look at that ovary and then go back over to the side where you think the pathology is and try again. And sometimes that helps. Sometimes that bowel will displace on its own.
In the case someone has two corpus luteums and only one IUP, not twins, does that mean there could be an ectopic?
Well, they ovulated from two different eggs, so there could be. But if they're not having, go by clinical symptoms and HCG, if they're not having pain, bleeding, and you see an IUP and there's two corpus luteums, I mean, I think that that's okay. Just make sure that that really is two corpus luteums and that one does not separate from that ovary.
Um, Same side, is the corpus luteum and the ectopic always on the same side?
No, nope. That egg can travel across to the other side and get stuck in the opposite tube.
Have you ever seen a confirmed ectopic with a very low HCG? I've seen sonographers say that they found an ectopic with a negative UPT, lower than 50 HCG.
Yes, I have seen one, and I think the HCG was like 140, and I thought that was very low. Um, and I have found a 1 centimeter ectopic mass, and yeah, it can be very low, it can plateau and then decrease. But if the patient is symptomatic, bleeding, having pain, then it's probably an ectopic.
Okay, let's wait one more minute. See, does it have to separate from the ovary if it is ovarian ectopic?
No, if it's an ovarian ectopic, it is on the ovary. Those are very rare ectopic pregnancies. 3% of the time, it is on the ovary.
Have you seen an ovarian ectopic?
Not that I know of.
What is the highest HCG level you have found an ectopic with?
I mean, those HCGs can be in the thousands, way above that discriminatory zone. And if there's no IUP and they're in the thousands, well over 2,000, then it's ectopic. You better try and find it. Otherwise, they're probably going to surgery anyway, because if it's not in there and that's the way above the discriminatory zone in the thousands or 10,000s, it's ectopic.
All right, I don't see any more questions coming in. Um, so I'm sure Lynn would be open to, well, she'll share her email with everyone when she sends the evaluation. If any other questions come up, feel free to ask. But we'll send the recording out to everyone as well, and feel free to sign up for future CME opportunities. Thank you, everyone, so much. We're so happy you came.
Thank you. I'm so happy to hopefully be of some help.
Have a great night, everyone. Thank
Thank
you for
you.
coming.
Thank you. Good night.
Bye.